Hi, I'm Dr. Sadie Larson, clinical psychologist and member of the ISTSS Public Information and Education Production Subcommittee. One of the goals of ISTSS is to disseminate high-quality knowledge and education to improve access to quality care for people who experience traumas. As part of that goal, the ISTSS Production Subcommittee is collaborating with people who developed or implemented the interventions highlighted in the ISTSS Adult Prevention and Treatment Guidelines to support widespread implementation of those interventions. Today, I'd like to welcome Dr. Susie Matthijssen and Jongh, who have done a tremendous amount of work in researching and training others in EMDR, which was identified as a psychological treatment intervention with a strong recommendation. So welcome, and would you like to just briefly introduce yourselves?
Okay, I'm Jongh. I'm a professor at the University of Amsterdam, Anxiety Behavior Disorders, and I have some positions in the UK. So most of it is training in people in EMDR, but also a lot of research going on with PhD students doing, conduct research on the area of EMDR therapy in a wide variety of conditions, mental health conditions, not only PTSD, but also PTSD with children, PTSD with people with intellectual disability, PTSD with psychosis, PTSD with all kinds of conditions. But now we are talking mainly about PTSD, I think, in this.
Yeah, perfect. Thank you.
Good. And my name is Dr. Susie Matthijssen. I'm also a clinical psychologist and, of course, a researcher. I'm the head of the Utrecht Academic Anxiety Center and the director of Enhancing Trauma Treatment Institute. And I'm conducting a lot of research also with ART and also separate from ART on enhancing trauma treatment. And a lot of the research I'm doing or did is focusing on EMDR. Yeah.
Yeah, we try also to improve EMDR. We call it EMDR 2.0 in terms of how we can.
Yeah.
We try to do studies in the laboratory and take it to the clinical practice and see how we can improve some of these parts of the EMDR procedure.
Yeah, that's correct. So we try to see what is the mechanism of EMDR, what is the thing that makes it work, and then we try to manipulate that part in the laboratory, so in an experimental setting. And then if we find a better result there, then we try to translate that to patient research. So we do a lot of this in this order. So first experimental research, and then we do it in patients. Yeah.
Well, I mean, that leads me into my first question, which is really what are the specific goals and key components of EMDR? And maybe you're speaking to a little bit how that understanding has changed over time.
Okay. Well, EMDR stands, of course, for eye movement desensitization and reprocessing. I think most people will know that part. And there has been a lot of debate on what is the working mechanism of EMDR. There have been ideas about that it is about REM sleep. There have been a lot of ideas about that it's about bilaterality. And there's still a lot of people that think it is about bilaterality. Because what do you do in EMDR? You bring up the most, disturbing part of a memory most of the time. We will also talk about other mechanisms of using EMDR, not only on memories, but let's focus on memories first now. And so you bring that up, and at the same time, the therapist will most likely move the fingers from left to right, and you as a patient need to follow the fingers of your therapist from left to right. So there was an idea that it was about stimulating the different parts of the brain, left, right, left, right. Well, there was already a very important study done in 2008 by Gunther and Bodner that showed that even this type of eye movements, so not horizontal, but vertical eye movements, had the same effect on people. And after that, a lot of other studies went on and showed the same thing. You can do any dual task, actually, and that has the same emotionally degrading effect. And so that is what you want. You bring up the most disturbing part of a memory. You give a dual task at the same time. Those two components, the activating component, bringing up the memory, and the distracting component, distracting somebody, they start to compete with each other in that working memory, because you only have a limited capacity of working memory. And then this task you will keep on fulfilling as a therapist. So it will have an influence on especially that memory. Yeah, so that will degrade in emotionality and vividness. And the very good thing is also that it will be reconsolidated as such. So with less
Yeah.
emotional intensity and less vividness. And
Well,
so
and laboratory studies show that the faster you go, the more the faster the desensitization occurs. So
yeah,
the memory is blurred more or less,
Mhm.
and so less vivid and less emotional. So that is support for the working, what we call the working
the
memory
memory
hypothesis.
hypothesis.
Yeah, but if
Yes.
it would be only bilateral, then there wouldn't be any difference between doing it fast or slow. But
Yeah.
all kind of research shows, yeah, the more difficult the task is, the distracting task is, the better the effect of EMDR therapy. So
Yeah.
in the beginning, we did one memory in a session, and nowadays we can do 2, 3, or 4 memories in a session.
Interesting. So the key components of the intervention have not really changed over time, but the understanding of how it's working have been updated over time.
Yeah, and also
Well,
how it can be improved. Huh?
yes.
Mhm.
Yeah. So indeed, we're talking about different mechanisms now than we did when it started to exist, EMDR therapy, but also indeed how you do it. Because back in the days, you would start with just bilateral stimulation, they would say. But
Mhm.
nowadays, when we look at what we call EMDR 2.0, we do all kinds of working memory tasks at the same time. To give as much distraction to the person, to give as much dual textation at the same time as people bringing up the memory. So yeah, it does change the way we think it works, but it also does change the way we do EMDR therapy.
Yeah, and with the overall goal of the memory of the trauma itself becoming less vivid, less intense over time. Is that right?
Yes.
Correct.
Yeah, great. And is there a specific target population for the intervention? I know, Ad, you were talking about that you're looking at many populations. At
Yeah.
this point, who would you say is or is not appropriate for EMDR?
So it's about mental representations. Mostly we talk about memories. Now, children have memories, the same effect. Uh, People with anxiety disorders have memories. So if there is a relation between a distressing event and a memory of a distressing event, which is recurrent, or people say when I bring it up, it's disturbing, and the complaints, the symptoms of the patient, and yeah, in PTSD, the symptoms are clear, that are memories, that intrusive memories, and people try to avoid these memories and so on, that they can't be triggered. So the whole system is like, there is a memory, it's activated, and people have complaints. So the most easy connection between memory of the event, and symptoms is in PTSD. But there are many kind of mental health conditions that have the same relationship. And now we are looking more at childhood events, ACEs,
ACEs.
yeah, adverse childhood events. So there are more types of memories, not only the so-called high A criteria events like physical abuse and sexual abuse, but also neglect and emotional violence can be how people with that kind of mental health of disturbances related to that mental health condition. Nowadays, we do a lot of research in the Netherlands, at least, on personality disorders. They have the same type of relationships, like the borderline personality disorders have the same type of connection between memories and and symptoms like complex
Mhm.
PTSD in the same way. Yeah.
Oh, that makes
Well, and
sense.
to add to that, so if we talk about groups of PTSD, there is no exception. So we see there is effect on combat personnel, we see there is effect in young children, we see there is effect in people with mental disabilities, we see there is effect in adults, also with all kinds of comorbid disorders, we see dissociative subtype also. So there is no specific group. If that was your question specific to PTSD,
Mhm.
there should be no group that should be excluded.
Yeah.
Yep. And what Ad is saying, yes, we also can use EMDR in different kinds of disorders. And in some disorders, there's only like a small amount of research yet. But there are also, for example, if we look at depression, there's already quite a lot of research done that shows that EMDR is effective there. So I think we have a lot to gain there. But of course, we need to first gather some knowledge about it and gather data. And so only data can, I think, convince people. It's not about only our clinical view or what we think or what we feel. It's about what the data shows, of course, and that is what we are doing.
So yeah, in comorbidities, for instance, we did a large randomized clinical trial with people that have PTSD and psychosis. And what you see, if you treat a PTSD in people that are psychotic and also have PTSD, the comorbid symptoms decreased rapidly. Also,
Yeah.
symptoms of psychosis.
Yeah.
Yeah, so
But we are
that's-
also Oh, sorry.
yeah. And that makes sense because these symptoms are also related to the damage that has been done by the event.
yeah.
Yeah, but we are also running trials on psychosis directly, for example. But
Mhm.
also on a lot of other different things like pain disorders, chronic fatigue or tinnitus or a lot of different disorders. There are studies being conducted, fear of childbirth, very, very different things. And one of the things that is so special about EMDR, what I believe, because I'm also a CBT supervisor, so I'm doing both things. But what I think is really nice is that you can directly target what we call a flash forward. So what you see a lot in anxiety disorders is, of course, that people are afraid of what might happen in the future. It's
Yeah.
always about fear about what will come, not about what is now. So if they have a panic disorder, I'm afraid of going to the supermarket because I can have a panic attack and I can die there, or I can faint, or I can lose control or whatever. And you can make a representation of that and target that directly, that mental representation. So I think that is also
The
something
same
that
effect.
is,
So EMDR has the same
yeah,
effect on that type of mental representations as in the way it happens with memories.
yeah,
Sort of
Yeah,
degrading the vividness, the
yeah,
emotionality, whether it's of a past memory
yeah.
or a kind of flash
yeah,
forward.
And
Exactly.
another advantage point is, I think, is that you can do it blind to therapist. EMDR is the only treatment that if people are too embarrassed about and it's too shameful to
Mhm.
say what happened particularly in sexual trauma, that what happened during the rape. Sometimes people collaborate with the perpetrator to give it let it happen faster. There's that kind of details you can ask people not to. You don't have to talk about it, but
Mhm.
just think about it. Just bring it into your mind because through the working memory hypothesis, you can say if it's in the working memory, you distract the patient on a high level. It becomes less vivid and less disturbing.
Yeah, so that could certainly be appealing to a lot of patients, I think.
I
Yeah.
think so.
And what about how you think about measuring treatment outcomes? So seeing someone clinically, how are you seeing if this is having the desired impact?
Yeah, well, I can tell you that I got quite some data, especially in our intensive program where we treat trauma in 6 days in an outpatient setting. So people come and go home. But we see very spectacular effects on PTSD. We see very spectacular effects also on comorbid symptoms, so on the BDI, for example, depression. But the king of data is actually Ad, because he has gathered so many data on so many patients. So actually, you should
In the
answer this
intensive,
question
yeah,
on
in the intensive.
in the
So
intensive. Yeah, that's
yeah,
correct. So that's a
so I
combination
think
that's good to sell.
yeah. So in intensive treatment, we combine exposure therapy and EMDR therapy. So we usually do 4 sessions a day in our mental health center. So 2 sessions in the morning, exposure EMDR combined, and in the afternoon also 2 sessions exposure EMDR. And we do it in 4 days, and 80% loss of diagnosis, 90% loss of diagnosis in complex PTSD. So there's so the combination, I think the future is combinations of different treatments with a
Maybe it's
different
good.
working mechanism.
Maybe it's good to say how many patients
Yeah, we treated
you
already
have.
1,000 patients in our center. Yeah, in this intensive form.
Yeah.
Yeah.
And is that, feel like Dr. Van Minnen, is that the same program?
Yeah,
Yes.
that's my
Colleague.
co-pilot.
Okay. Excellent. Yeah. Really, really interesting results from that. And as you're saying, a lot of, I think, complex presentations of people
Yeah.
coming to that program. Yeah. And
Yeah, and you were asking how we measure it. Most
Yeah.
of the time, we use clinical interviews.
Yeah. So the
The
CAPS-5 we
CAPS-5
use.
is our standard, of course.
Yeah.
CAPS-5 in the beginning. After we do it also after a week, and then 3 months, 6 months, 1 year. Yeah.
Yeah.
Excellent.
And of course, we also use subjective measures, so questionnaires like the PCL5, for example, the ITQ, all those things. Yeah.
We are researchers, of course.
Yeah.
That's why we
Yes,
want
you
to
can see the
publish.
influence of both of those. Yeah.
Yeah.
And how do you think about ensuring that EMDR is culturally sensitive for diverse populations, or as you think about new populations, balancing fidelity and cultural adaptation?
Yeah. Well, I can imagine we just in the Netherlands, we of course do it most of the time in a certain way, but of course you can make some adaptations like Ad said. I can imagine that for some cultures or maybe some man-women differences also here, if you have a male therapist and you're from a certain background, that it might be even harder for you to expose all kinds of details so that you can do it blind to therapists, for example. But we also can work together with translators, for example, that can do a part of the translation while you do the EMDR therapy. Of course, that is sometimes also necessary. It can be in how you address somebody, how you behave, how you sit, maybe keeping a little bit more distance. Well, the nice thing is you don't have to do it with your fingers close to a patient. You can also use all kinds of other tasks. So I think it's quite
And
suitable
please note
also.
that we have a lot of refugees from countries
Many.
like Africa, but also Syria, Ukraine nowadays. So we see a lot of patients, and the brain, I can tell you, the brain of these people is exactly the same as our brain. Only language is sometimes a difficulty. So yeah, we can ask translators to do it.
And I can imagine that just the adaptations that you have, it's the same as you have in other therapies. It's about the way you address somebody or how you sit or how you, and those are the same adaptations that you also need in other kinds of therapies.
Yeah, I think the biggest problem is there are countries in which mental health services are totally new. If you have a PTSD in some countries, they think, yeah, you're mad, and there's nothing you can do about it. So I think as soon as people know and understand that mental health conditions are treatable and also effectively treatable, then you win. Yeah.
I see that as something more general also, Ad, because I see that a lot, of course, the people sometimes from different countries, when they come in the beginning, they don't want to talk about it. They have the idea that something will explode in their mind if they will talk about it, that they get a lot of headache from it, and they don't see that as tension headache, but they see it as
Mhm.
might be something wrong with me. So what are you doing? I don't want to say something about it. I don't want it to, just give me a pill. I want medication. And so sometimes you need a little bit more of psychoeducation there also on, well, how the brain operates.
Yeah, yeah. But trust in the therapist is
Yeah.
important, of course.
Mhm. Yeah, that very important cultural difference, kind of understanding this as something that can be treated even, and that people can recover from.
Yeah.
And what resources or training do you think are required for someone who is interested in learning and starting to use this intervention? You know, where does somebody start?
Yeah, it's different in countries. In Europe, we say it needs to be a psychologist, a clinical psychologist,
Mhm.
and I think in United States, social workers are also eligible to be trained in EMDR. But let's say it's very important that they go to a trainer that is what we call it accredited.
Yeah.
Yeah,
Well, it's an
by
accredited training by their national EMDR association. And so that is quite important. And I know that a social worker in the Netherlands is something totally different than social worker in the States, for example. So it's really difficult to give you one basic level for
Yeah.
enter. But all the national EMDR associations, they have their own entry level. And you can just find that online in that country. But it's really important that you go to accredited trainings because unfortunately, we see a lot of coaches and people without any education that maybe had EMDR therapy. They want to learn it to other people. And yeah, well, I work at like a top clinical center where people come when somewhere else it went wrong.
Yeah.
And a lot of the times we see that people just got, yeah, EMDR with somebody who was not well trained and some strange things happen there. So that's the biggest advice that I can give is go to an accredited training and look that up in your own country where you can go to in your own national EMDR association.
And
Yeah.
important to say, it's not a long track. In the Netherlands, it's
No.
only 4 days with a lot of supervision in between, of course, and it can depend in other countries, in other states, even I think in the United States can differ, but it's not like psychoanalysis or something.
No, 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 no,
It's
no.
just a course. Yeah.
Yeah, so the basic level is 4 days. Then you have some supervision only towards skills. So it's not about you have to do so many sessions. If you look at skills of somebody, then you go to the second course, so to say. It's another 4 days, the follow-up course, and then you can have another supervision trajectory and then you can become an EMDR practitioner. Yeah, it's not a very long track, and it's very well focused on competencies.
Yeah, and yeah, you what you get taught is the basic what they call the EMDR standard protocol. That's why you start with. So how you can treat PTSD or simple PTSD, and you can attend to more higher level courses like what we call then EMDR level 2 or advanced course EMDR for more complex cases like complex PTSD or other mental health conditions. Yeah.
And you also learn there, of course, when something gets stuck, what do you need to do? If something doesn't go well, what things can you focus on? How can you do it? How can you do like what we call interweaves when somebody is looping in the process, for example? So those are all kinds of things that you'll learn in that level too.
Skills. Yeah.
Yeah.
It makes sense. I think that's something that's similar across the treatments is that they all
Yes.
sort of say you really need to do a good training followed up by
Yeah.
some
A lot of
supervision
supervision.
consultation
Yeah.
to
Oh yeah.
have a better sense.
Consultation, that's the word.
Yeah.
Yeah. We
Yeah.
call it supervision, but in other countries it's called consultation. It's true.
Yeah. Yeah, it makes sense. There's a lot of nuance to get right in this treatment and all of the treatments.
Yeah.
So what considerations do you think are necessary when you're thinking about sustaining this intervention, you know, for someone who has trained in it, they've learned how to do it for them or for a system. What is needed to kind of allow people to keep using this over time?
Yeah, I think if we speak from the Netherlands, we have a large EMDR association. We just had a conference, and I think we have 6,500 members in a small
More.
country, even more in a small country, at the highest density of EMDR therapists in the whole world. I think being a member of the association is the way you get new information, new protocols, new developments. People are translating the research that they read in the literature to other members. We do that in a magazine we have in the Netherlands, and we do that by conference. We just had pitches. Saturday we had a conference, and then there is always an hour-long pitches in which researchers tell in 5 minutes what they found and what are the new developments. And I think that's more or less the only way. Read about it, but yeah, the content of scientific published articles, that is not so easy to get in these libraries. So you have to find a way to get connected and stay in touch with research and the new developments, and associations are the best way to do that.
Yeah, so the association, well, I can only talk for I'm the vice president of the Dutch Association. Yeah, so the Dutch Association, I can tell you, it's a scientifically oriented association. So we really want to keep our members, scientifically well informed. So this is one of the things how we do it, and what I just explained on our conference, for example. But I think being a member of an association always helps. But in general, like in any other therapy, having enough consultation together with other peers that do the same thing, or regularly go to a consultation session of a trainer or a supervisor, or going to conferences, or doing extra trainings, or doing a refresher course, or things like that will always help to keep your skills, improve your skills, or to build more knowledge, or to gain more knowledge. Yeah.
Makes sense completely. Having a peer group around you is so helpful for just staying sharp with these things.
Yeah.
And what challenges and lessons, you both have been doing this for quite a while now and talking with clinicians, learning how to do it. What lessons have you learned from implementing this in different settings? Any advice that you have for agencies or clinicians thinking about implementing EMDR?
Yeah, it always has to do with knowledge. There's a PhD student that is doing her defense this week, and it's about stabilization. And that's one of these things. Do you want to stabilize people before you do a trauma-focused treatment? And when we started our research in the Netherlands on that is 2014 or 2015. At that time, there was a ISTSS guideline that say you have to do a phase-based treatment.
Yeah.
And that was a guideline based on just experts that state, hey, you have to do phase-based treatment when it's complex PTSD. We didn't believe that at that time, and we showed in our treatment centers that it was not necessary. You just go to like in the guidelines for PTSD. Complex PTSD is not different, only other symptoms. But there was a lot of debate in the Netherlands, and also a lot of debate in the United States, I know. And for us, it was very difficult to publish on that and say, hey, there's no literature at all that supports that idea of the ISTSS guidelines on this. There's no support at all. We wanted to publish it in the Journal of Traumatic Stress, and the editor at that time said, no, we're not going to publish that because it will split our community with people that believe in it or say we do that, and other people not. So here in the Netherlands, we started with 3 randomized clinical trials, one on EMDR, one on exposure, and one on imagery rescripting. Last 2 years, that the 3 trials were finished and published in the literature. They all 3 showed that stabilization is not necessary. It's only a waste of time, more or less. And now an answer of your question, it's very difficult sometimes to come with new ideas, research. There are always psychiatrists who say, no, you need medication. And then you say, yes, but here in this journal, it stated that, oh, but it's not randomized, or it's not this bad research. And no, and there's always depends on the level of knowledge in the mental health area context where you work. So now I think in the Netherlands, people say, hey, we don't do it this way. Look at the guidelines. The guidelines say PTSD, treat it like PTSD, and don't think that there's something more complex. Complex PTSD is a strange word, actually. It's not more complex. It's just PTSD with more memories and somewhat other symptoms. But if you treat the trauma in the core, symptoms disappear.
Yeah, getting to the root of the problem.
Yeah, well, I think, of course, it's difficult to change some things. If you want to change some things in treatment settings, and people work already in a certain way for years, it's difficult to all of a sudden just do it totally different. And so we also have the discussion about dissociation, of course. We always have the same discussion. People are really afraid if somebody has dissociation symptoms, and they say, well, then we have to do different things, then we have to stay away from it. And if you just look into DSM-5, it's just one of the symptoms of PTSD. So if I see dissociation, I think, okay, we should treat definitely and not wait. So yeah, I think we will always have discussions. And I think the main thing is that not only for organizations, but also for people to try to stay open-minded and to try to keep talking to each other, and always also try to look at the data. So if the data tomorrow shows us something different, we also need to change our way of working. So I think that is the most important message for everybody.
Dissemination of knowledge, and that's what we are doing now, right now. Eh?
Yeah.
Trying to say, hey, this is the state of the art now on EMDR. This is the state of the art on PTSD treatments. There are different strategies, different therapies, but they all do the same. They all are effective. And if you have a PTSD, treat it with something that has been proven to be effective. And that's why we need to go to keep and stay with the guidelines.
Yeah.
And,
so it doesn't necessarily have to be EMDR. There are also other guideline-informed treatments, and that is also fine. And just I think it's good to have different types of trauma treatment in your package as a therapist, so that you are able to switch if somebody's not responding to one type of therapy. And well, if you're not a fan of EMDR, also good friends. So nothing happens.
Yeah.
So I think this is something in the context of the Netherlands. It's very common. You say, hey, if you think you are a trauma therapist, you need at least 2 treatments that are you familiar with. So it's not about a fight between, hey, exposure and EMDR. No, you have both in your package, and you say, hey, in this patient, maybe exposure is more appropriate, or a combination with exposure and EMDR. Cognitive processing therapy or something else, but if you're a carpenter, you have more things in your bag than just one hammer. Yeah.
Yeah. And I think the program that you mentioned earlier is a good example of that, where there's EMDR and prolonged exposure and it working together. But also a good example, I think, of what you're saying, that this kind of feedback loop between clinicians and research, and saying, there's this kind of clinical idea that there needs to be stabilization. Let's test it and see what happens with that. And that's, I think, really important, whether you're talking on a large scale or an individual scale. Let me see how this works and then update my practice. And I think the last question, we've already talked a little bit about this. So the last one is just, have there been changes to the way that this treatment is implemented since its initial development? We've certainly talked about some of those. Anything else that you would want to say how this has kind of evolved, updated over time?
Well, I think there is still the standard EMDR protocol, of course, that everybody is practicing. It's just, well, Ada and myself, we want to make it more effective, more efficient. And so that's why Ada already mentioned in the beginning of this interview that we created EMDR 2.0, 2.0. So there we have a little bit more freedom to change things a little bit in that protocol. So that is what we are doing.
And
But
then we'll implement it in a randomized clinical trial and see whether
Yeah.
it's better or not. So that's
Yeah.
how we look at it. Yeah.
Yeah. So at the moment, we are running a randomized clinical trial at my center where we are comparing EMDR, the standard EMDR therapy, with EMDR 2.0 and also with another new trauma therapy. Yeah. So we are really excited to see those results coming. But we have to be patient.
Yeah. Yes, you've mentioned a lot of studies that I'm interested to see the results coming in the next few years, it sounds like.
Yeah.
Yeah.
Yeah, well, this has been super helpful. Anything else that you want to mention before we close for today?
No. No.
All right, well, thank you so much for making the time for this. I'm glad we could make it work across the time zones.
Well, thank you for the invitation.
Yeah, thank you very much.
Yeah, all right, well, great to meet you both. And
And you adapt a link, or we connect a link to the article that we wrote for the journal. Yeah.
oh, sure, if you can send that to me, I can add that.
Yeah. Yeah, yes, the Journal of Traumatic Stress, that's the article that we just wrote, huh? And I think it's good to when it's connected to the movie, the clip. Yeah.
Oh, yeah, the State of the Science article. Yes.
Yeah.
Yeah, that would be great.
Because it's open access, so yeah.
Perfect. All right. Well, thank you so much. Take care, both of you.
Okay, thank you very
Thank you,
much
you
for the
too.
invitation.